Oh,
Probably.
it's doing. It's good.
People
Relax.
like it when there's something to wait for. So, hey, welcome to the talk show, America.
4 minutes late.
We
Hey,
had
Four
everybody.
minutes late
well,
talk show.
I personally had some technical difficulties because I do not know technology, which is why I am not the national coordinator. And just to be clear, I know there's lots of rumors out there about how I am the national coordinator or am a candidate. I was never a candidate. That was a rumor Lisa and I made up when we were bored in the
Yeah,
bar.
guys.
So just to illustrate the
Come
power
on
of
now.
misinformation and disinformation, the fact that anyone is saying that at all, like you you should just feel in your heart if some news is correct or logical. So anyway, we have a lively news show for you today, and we also then have real legitimate special guest Sara Ratner, who for several years, I believe some of our colleagues called Dr. Sara Ratner because they thought she was a doctor. So
Are you
she's
serious?
not. She's a lawyer. She's a lawyer.
Well, I'm
So
a
yeah, anyway.
JD, not an MD.
Yeah. It's both of those are more than me, so that's great. So anyway, all right, we're gonna kick Sara off and bring her back on to legitimize our show later. And Melissa, anything to say before we kick you off?
No, I'm just happy that you both decided to come because I was starting to freak out.
Yeah, you
She's
could have
like,
done it by
I'm
yourself.
here.
I was like,
Neither
You
of
could have
these
done
I was
it.
weirdos
like, Lisa,
are.
are you
It
coming?
was,
She's like,
it was
I'm,
just a mistake.
I
Sometimes,
mean,
we haven't had technical difficulties in like at least 2 months, so I
y'all,
just was making
you
sure.
both did it to me though. I just want you to know that. I was like, Sarah, this is
Oh,
fine. It's all fine. It's all fine. It's all right.
yeah, it all worked out. All right. Anyway, Lisa, holy shit.
Yeah, I mean, what a year, what a month, what a week,
What a year.
what a
What a
day,
year.
what a
Yeah,
day.
yeah.
Oh
All right.
man, you guys.
So, dear loyal fans, we have organized this show in the following way. Our news show includes non-federal government related news, which is always sort of federally government related news, then government stuff, then how this is affecting America type stuff. So, just like hold your horses. Also, if anything breaks live, like 60% of HHS gets cut, could someone just like text us? That would be great. Don't
Yeah,
want to miss
yeah,
that.
yeah, yeah.
Don't want to miss that. We'll comment live. So, what do we got going on here? Oh,
That's right.
yeah. They fired their new lady CEO already over at Blue Shield, California. Yep.
No cross, just shield.
Yep.
Yeah, Blue Shield of California, really important pair here in California with just many, many like now decades of supporting like data and interoperability work. Paul Markovich, pretty serious about the space for a long time, supported Manifest Medics for many years, a big HIE here in California. And they hired a lady, they did a reorg, hired a lady to run the actual plan, and then fired her, as far as I can tell. Um, but I did note that she was from like United Healthcare many years ago, so I don't know if those are the same vibes as Blue Shield.
Yeah, you know what? The thing about right now is you can release pretty much whatever news you want, and I guarantee the
Nobody will
feds are doing
notice,
crazier
right?
shit, so it doesn't even
Just
matter.
us.
So we have no details, nor did we have time to even snoop. So that all we know is this happened.
Yeah,
Oh yeah,
yeah, yeah.
other news that's interesting in health tech that's not related to the federal government cutting half of its staff. Hinge Health is going to IPO. What?
I mean, personally, if I were running an IPO, I would not right now, but like that's just me. Like I
I
would say like,
mean,
sorry guys, not a good time.
I also like had zero time to read any of the 14 million analyses of why this was cool or not. In general, like I've heard that they were going to do this for like years. I feel like so.
Yeah.
I'm delighted that's happening. I'm delighted something's happening in general. I don't know if anyone's going to make money off this, but if you
Yeah.
do, like, God bless you. That's awesome. Here for it.
Well, I think
Do we
also
do we
like
like Hinge?
everybody's been waiting for like an actual digital health IPO for a long time. Ever since ever since Glenn Tolman did his stuff. No comment, no comment. Um and I think it's a good idea, Hinge and Sword and those other companies. I don't know enough about the business fundamentals to really comment, but I do think that it will be very influential should it be successful. And I am questioning whether it is a good time to IPO. So I don't know if it will be successful.
Yeah, I don't know.
No,
But
no,
everybody else is going to watch this for us, so we look forward to copying and pasting the
that's right.
headlines into our talk show.
Totally.
Oh yeah,
Do you want me to comment on this one, cat?
yeah. I just have one comment. If you could just comment. Also, we love Alia, so like we posted
Yeah.
her assessment or part of her assessment. It's quite long. You should go read her stuff. It's always good.
Yeah.
Yeah, Lisa, it'd be great if you just like talked about this.
And read the comments too. I don't think you put the really important meme that Brendan Keeler created, but the point here is that like screen scraping apparently not dying. And basically like this is some legal stuff. Maybe Sarah can remember how legal stuff works, but basically like the Point Click Care's counsel had said like you should dismiss this case because it's dumb and wrong, and the judge said, no, we are not going to dismiss it. It can proceed. And that's basically what it is. If you read the actual, read Alia's like commentary here and read the, if you're interested, read the actual thing because they say some really questionable and like read Brendan Keeler's analysis also. They just some really questionable assertions by the judge, including by the Fourth Circuit, basically asserting that patients own their medical records and this is why it's wrong, which unfortunately legally is not true. That's just not how it works. There's a bunch of weird stuff where you're like, that's wrong, and that's wrong, and that's wrong, and that's the basis on which you're making this decision. So it feels like it's wrong. I think that Point Click Care have done something else to like again file to dismiss. I don't again know all the details of the case, but this was a weird one. Continues to be a weird one.
Yeah, the only thing I'm going to say about this is I strongly disagree with the judge.
I strongly disagree.
I strongly disagree. Um, I will not go into all of the misinformed comments on the internet about this. And I hope Point Click Care keeps going. I hope Point Click Care keeps going because this has massive bad ramifications for the industry.
Yeah,
And it is
yeah,
hard to find a judge who understands the healthcare industry so well as to make a good decision on this. So
yeah.
those are my thoughts for
Great,
now.
amazing.
Yeah. Yeah.
Loyal
Okay.
fans read between the lines.
Or look at my look at my LinkedIn profile and figure out where my I don't know. Anyway, Lisa is not in this picture, but she was right in front of the audience at South by Southwest, and she actually strongly participated in this panel. This is
Once
a
again,
group of lovely individuals: Leslie Kirk, who is our moderator, Brendan Talley, Dr. Brendan Talley. Who is the Chief of Programs and Innovation. I might get those out of order for the CDC Foundation, JT Lane, SVP at ASTO, me, random girl, and then Dr. Matt Christensen, who is the CMO of Valley Health, also the vice chair of the West Virginia First Foundation. So we did a presentation down there in Austin this past weekend with also Lisa Berry, a prominent member of the audience, about decentralizing public health, and like maybe we should all get used to the idea that the CDC is probably going to be cut in half, and how do we still make public health things matter. So obviously it was great because it was our panel, but I actually think we said really awesome
it's
things.
actually
I
good.
think
It's actually good.
Mayor Ritesh Patel, mayor of the internet, he'll be posting the videos from this whole day. I think later this week, or who knows, it's the end of the week, but sometime soon, and we will let you know. There were some other good things too, like our bestie Grace Cordovano, Erica Olinsky also did a session on, patients first and stuff like that. So totally worth it. Ritesh always does an awesome job. So yeah. Also, there
I
was a
took
gentleman
some
in the
amazing
audience.
notes. I took incredible notes, and like I
I
at some point
didn't.
I'm gonna actually like post them because there was some really like Matt Dr. Christensen was amazing. Like he had so many cool
Yeah,
things to say. Like really great
that guy was great.
experience. He was
That guy's
great.
great.
So
Also, one of the reasons, I mean, we like everybody here, but Matt is a very notable human here on this panel because he's from West Virginia. He's the former state health officer of West Virginia. I don't know if you guys know this, but like West Virginia never had a lot of resources. So for him, he's like, well, great. Like we're used to that. So he actually had like a
yeah,
lot of good things to say and like how to be
he did.
scrappy and how to get it done anyway. It was really good. So we plan on
Good.
taking him around a few more times this year to talk about this stuff, but it was good stuff. There was also a
He did a
gentleman in
really
the
good job with
audience.
like he did a really good job with the communication of like he was like, hey, when people are trying to struggle, like struggling to understand like what's going on here, public health is prevention. He's like, I'm telling that to everybody I know because it's easiest to understand. This is why we do this, is why we invest in it. It's really critical. upstream of healthcare conditions, of medical costs, we have to absolutely have to invest in prevention. And that's an easy way to explain it to me. It's maybe not like the perfect, correct, like academic view of what public health is, but it's an absolutely clear message of like why you should care about public health.
Well, public health should always have been working with Medicaid, honestly, like at least from like a money perspective. And
Totes.
like, I feel like total missed opportunity. I know that there are some groups advocating for this now. Thank God, finally. Also, like maybe a little too late, but whatever, what's new?
Right.
So, all right, we're going to move on because we got some other stuff to talk about. But Lisa, there was a gentleman in the audience who predicted the big cuts that we actually saw at CMMI this week. So we'll get into
Yep.
that.
Yes, you
Okay, so
did.
speaking of the government, like apparently today, I don't know, it's 4:44 p.m., but I don't think this administration cares about working hours. There's supposed to be some massive riff happening, probably,
Yeah. 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 Yeah.
maybe, sort of. We don't know.
I think it's today. I think it's Monday. Heard from some unnamed federal colleagues that they're being asked to show up on Monday with just what they can carry, which is not doesn't bode well.
I don't know. Or maybe they
And
don't
keep
want a
in
lot
mind,
of clutter,
don't want a lot of clutter because remember, everyone, loyal fans, um, the federal employees, especially HHS, who have not yet been let go for various reasons, are being required to return to office in almost all cases. And that means like if they live near an office, they have to go there. Even if it's not like Baltimore CMS, they might live near the federal building in another big city and they might have to report there or somewhere else because there are too many federal employees to fit into all the buildings they have. So, like, Monday is RTO day, and they are literally putting people in like conference rooms, like co working spaces, you name it. And so,
Well, that
this is
sounds
the
cuddly
day.
and snuggly.
Definitely cuddly. I predict a
Yeah.
increase in COVID,
Well, I'm not
bird
worried about
flu.
that, but I do hope that people can bring their house plants, office plants in soon.
Yeah,
Okay, so we had that. There's like supposed to be a big riff, but then also last night, I think two separate federal judges were like, "Nah, you got to reinstate all these workers you already
right,
riffed,
right,
or
right,
you fired for performance on probation." It's unclear to me, like if the government is actually going to take these people back, or if they're just going to
right.
say, "F you," like see you later.
Yeah, like okay, we illegally fired you on your probationary period, but now we're going to reduction and enforce you. We're going to riff you. So which one is it?
Yeah.
Like I don't I mean I hope for the people who were let go on probationary periods because I think that was pretty much, not correct if they were given information that they were performing poorly. That's not the reason why they were let go. If that's the case, I hope they get reinstated and get back pay, but I also think it doesn't protect them from being riffed like anybody else.
Yeah, I don't know. We don't know. We don't know,
We don't
loyal
know.
fans. If you know, let us know.
Yeah. Signal us.
So the only oh my gosh, Michael's here. Oh my God. So the only thing that we've seen so far, or at least that I've seen, because normally I rely on other people telling me things. The only reorgy thing that we've seen is this OGC thing, which is
Yeah.
not terribly exciting for me, but I bet there are some nerds who think this is totally freaking awesome.
Hello. I think it's exciting, obviously,
That's
because
why
I'm
you're
a nerd.
here. Yeah.
No, it's just another like this is a fairly logical reorganization that apparently has to go through the Federal Register about how OGC, that's the legal counsel at HHS, they're organized to provide oversight to the different agencies, and they just kind of reorganized a few things, and they put the ONC oversight in the same group, the same branch as the privacy side, the Office of Civil Rights, which is good because health information privacy should go together. But it might mean something else bigger. We'll see. We don't know.
Yeah, I don't know. We'll see. This is exciting. We follow Lud Wiley on X. You probably should too. He's not like a really regular
He
Xer
puts a few
tweeter,
bangers out
but
there.
there's some bangers out there. You guys should
That's
follow him.
right. That's right.
All right. Oh yeah, and then apparently you told me this was leaked, Lisa, which did look like it was leaked, and then they put out this
Yeah.
like fancy statement. So they
Yeah.
cut what, seven models?
Between 4 and 8, depending on how you slice it. I think that someone basically, as far as I understand it, CMMI went through their model list and said like, this is too expensive, this doesn't make sense. and um, and they cut a few things. The biggest thing they cut was a model called Making Care Primary, which is a big primary care innovation model that was released, I guess, last year, started last year, and it's meant to be like a 10.5 year model, like an 8 year performance period. Big deal. I was really into it. I love primary care. I love primary care innovation models. Apparently, it wasn't getting as much of an uptake as they had hoped, but also a 10-year model costs a lot of money. And basically, they cut a bunch of stuff, they ended things early, and they claim with that they've saved $750 million. The timing and the reporting from Axios looked like a leak, and then right away, CMMI, CMS their released their official statements because I think they were like, well, got leaked, so here you go.
Kind of into people who have the balls to leak this stuff. Like, good for them.
It certainly wouldn't be me because I'm too paranoid and love authority too much, but it's interesting. I mean, I do I would just be like, I'm gonna get caught for sure. I probably would because I'm not very good at hiding things.
Well, I don't know. This, got to respect the leakers.
Yeah.
Okay. Also, SAMHSA is getting cut by 50%.
Yeah, this is a big bummer because as you know, we have a bit of a problem here in these American states. Not great.
Yeah. Okay. I will say, it's interesting though. I know that SAMHSA has been widely criticized for not getting shit done. What do you think about that? Do you think they
I
just
mean,
needed more people?
like probably not, but indiscriminate cutting is not necessarily going to get us the
Yeah.
results we need either, right? Like, of course, probably people there who weren't doing a great job, or systems or structures, not that it weren't great, or leaders that weren't great, but I don't love the indiscriminate cuts. We'll see how it shakes out.
Yeah. Also, oh, I'm not sure. It might have been in that first article that we copied and pasted from Politico, the Politico News Alert about the overall 50 to 60% cuts that are allegedly supposed to be announced today, but TBD. No one has texted us yet. AHRQ, is allegedly being cut by 80 to 90%.
That's a big cut.
So
That's a big cut.
yeah, if you read that Politico Pro piece from last night, and I think Aaron Carroll of Academy Health put it out on LinkedIn today, they are getting the USAID treatment. They are getting doged, carved out like a pumpkin. So
Yeah, yeah. Well, they
not
have to.
great, not great.
My sense is that Doge has been given a particular number they want to get to, and they're trying to find wherever they can find it. And maybe they're finding some agencies that have less political support that don't feel like they're widely understood, and they're like, cut them.
Yeah, not great, not great.
Yeah, yeah.
Oh yeah. Oh, and then also, okay. Before I go into that, I don't know. There's like 1,000,100 rumors, but also there's a rumor that ONC is getting cut down to 30 people. It's getting un-ASTP'd. There's HRSA is getting just
Un-ASTP'd.
un-ASTP'd, getting unalived from that perspective. Like, there's just all kinds of stuff. So, but the thing is, no one fucking knows.
Yeah, yeah, yeah. Lots of
It does
rumors.
sound
Lots of
it does
rumors.
sound like the ARC thing is true based on the people
Mhm.
who have told us they would know. TBD, y'all. TBD. And
That's
it
right.
looks like, I don't know, is the government gonna shut down? I don't know. It's not, the thing isn't signed yet. It's not voted yes. The CR is
Um,
not done.
No, and in fact, Nancy Pelosi, even Hakeem Jeffries, who doesn't seem to have too much of a backbone, sorry, but you're a public figure, and a bunch of other people who, congressional Democrats are pretty pissed about this because they were like, no, why should we support this? And so there is definitely a big political fight happening. There was political reporting from yesterday where reporters were hearing Democratic senators screaming at each other from behind the closed doors, like fully screaming at
That's what
each
I'm
other.
talking about.
So it is hot. It's hot. Uh,
I like it.
so
Yeah.
not totally clear.
I hope the Democrats figure out what they're doing. Like,
Yeah, sure. I mean,
yeah.
don't hold your breath. Don't
Yeah.
hold your breath.
I just wish that happened. So we'll see what happens. The government might be open, the government might not be open. I decay.
Yeah, no,
We'll find out.
literally, just like we can't tell you when and how big these cuts to HHS are going to be or other government agencies, we cannot tell you if the government's going to be open after today. We don't know. because it is
You
probably
know,
really touch and go right now. Nothing is signed.
it's probably touch and go, touch and go,
Yeah,
touch
yeah,
and go.
yeah.
Also, this is a fake news show in case you guys forgot.
Yeah,
So,
this is not real
we will
news.
find out with you by 12:01 a.m. tomorrow. We will find
Right.
out, loyal fans.
We might find out in a
Also,
text
yeah,
during this meeting.
we no longer do health related social needs. That is not something we
Yeah.
do. So
Okay,
this
okay,
is
okay.
older
Oh,
news, but we
okay, okay,
missed our
okay.
show last
No,
week.
that's not what this actually meant, just to be totally clear. First of all, there is a new head of Medicaid who I've asked people who should know, and they're like, I don't know who's in charge of Medicaid. It is Drew Snyder. He used to be the head of Medicaid in Mississippi, and it was like not widely announced. Again, I asked a bunch of people, like, I didn't know that. It was not, as far as I know, super publicly announced, but he is definitely in charge of Medicaid. He is relatively new in his office, and one of the first things he did was submit a memo that rescinded some previous guidance around health-related social needs. But it said, we will not auto approve waivers around health related social needs. That's pretty much what it said. And that is rescinding guidance, but it's not saying we won't do anything at all ever. So just to be clear, fake news show, fake news alert.
That's what I'm talking about. Yeah.
That's right.
Also, this guy, I don't think Drew Snyder was broadly known, like,
No,
because
no, no,
I
no.
think he got as much exposure as some of the other players. Like they were all put in a WAPO article. Like I think
Yep.
they were just like, we don't know that guy.
I think it's an important job, and I'm like surprised there wasn't more visibility or awareness about this, about Drew, who
I don't know.
friends of friends, colleagues of colleagues know him. He's a real person. He led Medicaid in Mississippi, and like I don't think he got much coverage, but I guess there's a lot of news.
There's a lot going on, America.
Too much
Like
news.
this, apparently, many of our fine academic institutions will be just slashing and burning their
Listen,
staff. So not great.
not
Like,
great, not great.
I mean, it's like a lot. It's like a lot of money that's not around anymore. So
It
we'll see
is,
what
and
happens
Johns
here.
Hopkins like is particularly vulnerable, as this story said, but like, hello, Harvard has more money than like most countries, I want to say, and they also cut a bunch of people. And I feel like, what's the point of your massive sort of endowment if you're not going to, employ people to do important work? Like, what are we doing? What are we doing? I don't
Yeah.
know.
And again, I think there's a lot of waste, like to be clear. I do. Like I just feel like a
Sure.
lot of this is like butcher knife versus the scalpel. I don't know. So this was I think we all like heard this story was coming out and
Yeah,
thought it was
yeah.
gonna be like quite the expose on bamboo, which runs most of the country's PDMPs. Like I read this and I was like, no, like they're doing what the state told them to do. And
Mm-hmm.
this is Louisiana, right? Louisiana has
Mm-hmm.
classified various abortion drugs, including I think both mifepristone and then the other one that I always forget
Misoprostol.
as controlled substances. So everybody was like, "Can you believe bamboo?" This is not everybody; it's like 4 people, and I was like, "No, I know exactly why they have to do that." So I think this was kind of like, yeah, like that sucks. In general, it sucks that Louisiana is doing this. I think that's shitty and not cool. But what the hell's new?
Well, I guess I also just think like how many times can I say until I'm blue in the face that we need comprehensive data privacy and protection laws in this country, ideally one law. It's hard to get to. There's all kinds of reasons why that's difficult, but the reality is like maybe you say, "Hey, I think abortion pill prescription should be tracked as controls." Great. What about something else that would also be like embarrassing or harmful to you personally? Put it on like turn it around. Like, what's the other direction of this? I really believe in health information privacy, and I really believe that we should have more controls and have more of the ability for patients to actually consent about what happens to their data. And like again, this might agree with your politics potentially, but turn it around to something that doesn't agree with your politics. And now, how do you feel about it? So that's why we should really work really hard to make sure that people's health information is private and they can control it, and that we can't divert it for justice purposes in whatever state, whatever law. California or Louisiana or wherever else.
Like, what about boner pills?
Boner pills, yeah, for sure.
Do you think,
ED
like, if
in
we just
general.
like,
Yeah,
yeah, like, I
totally.
feel like I would be into that.
Yeah, okay.
I think that's
Controlled
meaningful
substance.
information. That's
Yeah,
meaningful information. That tells us about what someone's priorities are. Like,
sure, totally.
I'm into it.
You know, Cialis,
Anyway, hey, Lisa,
reportable.
speaking of this, like, so, you just said like a single privacy law, like totally, except that it could be this law.
Sure.
So,
Be clear. Right?
Like,
No.
God bless our states is what I have to say about this. Thank God for the states and our many different rules and laws. Yeah, Michael wants to know, can they track the little blue pills?
Yes, they can.
I think they can do all kinds of things. But what do we think about this national PDMP rumor? Do we like the national PDMP? I sure don't.
I do not. I am not a fan, and that's
Don't
a
like
no.
it. Not
No.
into it.
No.
Nope.
I think
So we'll see what
PDMPs
happens
have kind of
there.
like run their course. I think we're good.
I
Like
think they're so boring.
Yeah.
Like, I mean, I think the states that use them for law enforcement, and I know a lot of the blue states just like don't. This is like illegal, but a lot of the red states they use them for law enforcement, and some of them are run by DOJ in the states. So
Yep.
I just feel like I've been saying this for years. Like, let's just get pharmacies connected to HIEs and like not suck. Like,
Yeah.
let's just make that go. And then just like PDMPs can die and they can take their last gasps of breath in the corner like the dinosaurs. Like, I'm ready.
Sure.
PDMPs should just go away. They're super dumb. We should not have a national one. That would be stupid.
Yeah.
Or I'll just gonna go to the black market. Oh yeah, and then international news over here in the talk show. Sometimes we do international news. NHS England. What's so great is the headline that I read this morning is NHS England being abolished. Like they are like using American gringo language.
This is also not accurate. Like NHS is not being abolished. It was the worst like headlining I've ever seen. And no, it's just literally like administrative organizational change. But of course, like, people just repeated like they're getting rid of the NSH. Do you know like do you know what kind of like there would be there would be there would be there would be a new revolution, an English revolution, a British revolution if they tried to get rid of the NHS. If they tried to get rid of the NHS, like in the United Kingdom, there would be a new revolution, and it would be bad.
No. So this is they're just pulling it back under. It's a government. It's going to be a government thing again, right, or whatever. Yeah.
Yes.
I mean, I do love the drama. I feel like the UK is always high drama. Like I'm into it.
Oh yeah, big time. Yeah. Also, King Charles is like releasing his like podcast and like Spotify playlist. So it's good times over there. Yeah. Good times. Men love to podcast. Men love to podcast.
You know what? So do women, though we wouldn't know because this is an online internet talk show.
This is not TV a podcast.
This is not a podcast, but I hear that that's a thing. So I don't know. I also know that President Trump is now selling Teslas. So bets are off over here. I don't know. You can.
By the way,
you know what, people?
Kat famously bought a Tesla recently. So
I did it, and I used Lisa's referral code. Yeah, keep those rumors flying, America. Keep them flying. Keep them going. Yeah, she also slept at my house for several days. We shared a room in Austin.
We have so much dirt on each other that we could never turn on each other. That's the bottom line.
Anyway.
Oh, man.
Okay, I think it's time for our very legitimate guests to come on here and make this talk show great again.
Make us legitimate again.
Okay, all right, where we go? All right.
Oh, Sarah.
Lawyer Sara Ratner. Oh my God, Sarah, what do you want to say?
She's not a doctor.
Before we ask you, not Dr. Sara Ratner, would you introduce yourself for our fans? I feel like everybody knows you, but we just need to start again.
I'm Sara Ratner. So that's about, just Jack, like Will and Grace. I'm just Sara Ratner.
Just Sarah.
That's right.
Okay. Well, Sarah, what do you think about America right now?
Really proud to be an American. It's, I think there's a lot of opportunity for really smart people to do some creative things and use this opportunity for trying to improve healthcare in the best way. But I'm kind of cynical, frankly.
Yes. Well, you are very close to Canada.
I know.
They
And,
don't
you
they
know,
don't want they don't want them. They don't want us. They're closing the border for against
I'm
Americans
kind of
right
like
now.
crawling across the border, making plans just in case I need to evacuate. I mean, you know, I guess they're turning off power to my state pretty
Oh
soon.
no.
I don't know. I mean, maybe the lights are going to go out on the show. You never know. You never
I don't
know.
know. We hope not. We hope it makes another 27 minutes. So that would be great. Okay. All right. But like, okay, we're not going to make you talk about that too much unless you want to, in which case we're all in. But Sarah, you have like a really cool background in, well, lots of things. I know you are responsible for a lot of really cool things from the way back, like the Minute Clinic. You also are a huge advocate for opioids and using Medicaid to reduce recidivism. All these things we always love that maybe are not super trendy right now. Maternal health, all that stuff. So can you just like tell people what's going on in your world with that?
Yeah. So, I mean, as you mentioned, we're focused on right now really studying maternal health. As you guys know, it's the number one issue that state Medicaid offices are focused on. And we actually just published a study in the American Journal of Managed Care last week that talks about ways to effectively engage new moms in pre-postnatal care, and the ways that we can effectively do it. So really interesting work in the maternal healthcare space. Also, as you mentioned, has spent a ton of time trying to figure out how do we address the opioid crisis. And nobody has the secret sauce for it yet, but we know that 80% of people in prisons have some type of substance use disorder, and it doesn't get any better when they're released. And so we've spent a lot of time trying to figure out how do you get people who are in that position, not only effective care and care to continue post-release, but also all the other social services that need to be surrounding that person in order to help them actually re-enter society. And unfortunately, it's kind of been an area that's marginalized and not focused on. It was focused a little bit with the new 1115 waivers, but I suspect we're probably, you know, if health-related social needs are going away, then probably other things like this are going to sunset at some point soon.
Yeah, we had friends of the show from mostly Medicaid on a couple of weeks ago, and Chris Valama was on saying it's a real possibility these waivers get pulled back.
Yeah, yeah,
Not great.
It's I mean, our clients who are mainly, you know, Medicaid and Medicare plans, they're in a state of just paralysis. They can't move.
Right.
And there's nothing that can be done right now in order to get them to take action because they don't know what's going to come down, you know, what regulation is going to come down, what's going to be removed, what's going to be changed, what unilateral decision is going to be made. It's crazy.
Yeah. Yeah, it's not ideal, that's for sure. And you know, I know you mentioned a bunch of different things, right? Opioids, moms, all that. Like a lot of times, all these things go together.
Oh yeah.
And some of the like we just saw the mom model is one of the like Lisa is one of the models that was sunset from CMMI.
It was, but to be fair, the mom model was very small and it had a really kind of complicated design. And as far as I can tell, they're continuing the transforming maternal health model, which was the longer one.
Okay.
So mom was in the very end of its cycle. It was like, I think the last year, and it was a pretty small model that hadn't had great sort of pickup. The idea, like generally good, not sure that that model design was the right design. I think it's okay to like cut off experiments like that if they're not having an impact. But I
Yeah.
am concerned because like I generally think that this is an area we need to be focusing on and that we need, you know, payment and care delivery innovation. I'm not sure that CMI was the right place for it at that point in time or that the mom model was the right choice for that. That is my take. I mean,
Yeah.
Sarah, I'm sure you have an opinion on that model or those different types of payment innovations around it.
Yeah, I mean, we've been focused on the TEMA model with
Yeah.
the states where they were granted dollars. And I actually think it's fantastic in the way it's trying to kind of surround the mom with navigator, doula. I mean, think of it as like when I was at Minute Clinic, we were kind of new to the market with physicians. And that was at a time where primary care was not enough physicians or providers. And we had nurse practitioners, which were referred to as extenders. And now things like the TMA model are using extenders like doulas or lactation support consultants to actually figure out ways to deliver care when we don't have enough OBs or nurses. And I think it's a fantastic model, and I hope that it doesn't go away or the dollars aren't pulled, because we know that the states who are rewarded the dollars are the ones that need it most.
Yeah,
Yeah.
definitely. Yeah, I mean, I think this initial cut to CMMI models was obviously a surprise. Nobody likes to hear that. And it's not, there are definitely some real concerns about how CMS and CMMI are going to support primary care, because this big primary care model and a ending primary care model were canceled. Primary care first and making care primary. But hopefully that will give them some more flexibility to do some new stuff. And also, hopefully, it means that they're going to keep the other models in place, like transforming maternal health.
Also, this just in, unrelated to not Dr. Sara Ratner. They are now thinking the RIF announcement will drop tomorrow.
That's Saturday.
That's so sad.
Why not?
Man.
Also hearing, in addition to the 80 to 90% RIF at AHRQ, ARC, there will be an 85% budget cut. So they are getting USAID.
To ARC or to
ARC.
The budget cut reference was also to ARC.
ARC, yeah.
Well, if you cut 90% of your staff, I guess you can also cut 85% of your budget.
I guess so. I don't know. So that's so we'll see. We might not get that real time alert that all this is happening until maybe tomorrow. So we'll see what happens. Yeah. All right. So Sara, you guys have done your team has done a lot of interesting things. And to be clear, your team has been at Nomi Health. I think we skipped that part because we were just saying you're just Sara. What is different about the approach y'all are taking to maternal health, to opioid use disorder? Like what's the dirty dirt?
Yeah. So, when you engage with the system, we're forced to engage in a way that fits the system's needs. And so we have to call the doctor. I mean, even just today, I'm emailing my doctor and she doesn't email me back, and it takes me a week to get a response. And, if you look at my chart, I'm due for a visit. Well, I have to be the one to initiate it and schedule and work around her tight schedule, and, was told that I can have a visit in September of 2025. Well, that's stupid. And so what we said is we need to create a system where actually the member or the patient is the center of it. And so the model that we set up here at Nomi with our integrated programs is to really say, we're going to take all of our data and analytics. We're going to understand the gaps in care that exist for a member. We're going to then do engagement based on the studies we've done and what's most effective. So for example, women in maternal health deserts, 80% prefer phone calls versus SMS, which makes sense because they're in, broadband deserts. And so we use kind of those engagement vehicles. And then once we get a hold of somebody, we offer on-point telehealth visits that close the gaps in care. We don't say, we're going to schedule you for 3 months out and hope and pray that you actually make your visit or have transportation or your job allows you to take time off work or you have childcare. We do it right then so that we have been able to see we're closing 10% of the gaps within 7 days. And it really has changed the paradigm for bringing care in a way that is effective for people and meets their needs versus us trying to get people to cater to what works for us. And, it also goes to the system has tried to isolate things in silos. So if you have high blood pressure, physicians are supposed to reach out to you and say, let's get you in to control your blood pressure. Or are you taking your medicine? Well, what about all the other comorbidities that exist? And so when we talk to our patients, we have the data that says, here's where all the gaps are. And we talk to them about all the gaps instead of saying, we're going to use this as a prenatal visit and that's it. And we'll call you back in a week and then we'll talk about your blood pressure. Well, that is also stupid to do it that way. So we're trying to take everything and make it really convenient for the member and the patient and centered around their needs versus ours. And, it's proven out to be a really effective model, and our patient satisfaction is is 95%. They rate our quality care as 92%, and we have a 76 NPS. So I think we're doing something right and solving a market need that has existed.
How is this different from, because like, I mean, I love what you're saying. How is this different from like a Pomelo or a Maven? Because they use the same words.
Yeah. I mean, think of them as like, they will be the physician of record. We are not looking to be the physician of record. We're looking to reroute people back into their physician of record. So last year, 57% of the patients that we saw had not seen a primary care provider in over 15 months. That's pathetic. Half of them were assigned to an ACO. So these ACOs are getting money for the attributed patients, but they're not seeing them. Really? Is that how we're spending our money? I mean, we talk about like fraud, waste, and abuse. Hello? Like,
Wow.
Should we abolish ACOs?
I think we should hold ACOs accountable. That accountable word has kind of lost its meaning in ACOs.
Interesting.
So
that's a spicy take, Sarah.
Yeah,
I like it.
I'm into it.
It's well, you know, when we look at the data and we work with the patients, we see that. And 60% of the patients that we saw wouldn't have known where to go had we not gotten in touch with them. So this is saying something about our system that's serving Medicaid beneficiaries. It's not working.
Yeah,
Yeah,
I'm
I mean, I
actually
guess
just looking. I just got sent this Milbank Memorial Fund just put out their Health of U.S. Primary Care, their 2025 scorecard report. It's titled "The Cost of Neglect," so you can imagine what's in here. And yeah, they're also not particularly pulling any punches because it's grim, right? The reimbursement, the access, the what you're saying, your experience, right? It's just like bleh, not good.
I think Michael's saying, can we not abolish ACOs?
Michael does not want us to be dissing ACOs on the show, but
Yes.
Michael,
Make ACOs accountable again.
Michael, you are not a sponsor of this show. You could be. You could be. And then we would say a nice thing about ACOs, followed by a mean thing about ACOs, followed by a nice thing about ACOs.
Well, that's the thing. Our sponsorship form does say you have no editorial control. Thank you for your money and support. God bless you. Like, see you later.
No. But to be fair, ACOs do play a great role if they're seeing the patients that they are supposed to be seeing. So there is a place for them. It's just
right.
You know,
like you're saying somebody needs to fill these care gaps. It's not happening. And like it needs to happen urgently. It can't be a see you in 2 months, see you in a year, or you have to do all the work. Like people who are busy can't do that. They can't go see their doctor at like 10:30 a.m. like 7 months from now.
No,
not going to happen.
You can't. No. And the other thing we heard is like, you know, the ACOs don't want us to touch their patients. They don't want us to reach out to them.
Right.
And so we're actually serving a benefit because we're getting these folks back into their primary care providers, their ACOs. And so if we can't touch them and they're not touching them, well, you know, they're not getting any health care. So somebody's got to help them.
Right.
Yeah.
Right.
And y'all aren't just a tech platform that shows gaps in care, right? You have like humans who are doing outreach and you know,
we do. We have a call center, we have clinicians, and you know, that's just our integrated programs. We, you know, haven't even touched on the cool stuff that you know about CAT on the, you know, real-time payments and you know, kind of the network side. So Nomi's doing a lot of fun stuff, trying to solve some big problems.
Yeah. Very cool. So can I ask you an unrelated to Nomi question? Yeah. Okay, so you were involved in the rollout of MetaClinic, instrumental, as I may have made up in my mind. Did well. That all worked. So why do you think all this other stuff like Village MD, Iora, like how are all of these purchases for like, you know, essentially something similar, just taking down these companies? Like what do you think went wrong?
I think they tried to do too much. I mean, the beauty of MetaClinic is it was very focused on cold cough flu and addressing a need in the market. And it kind of continued to grow and grow and grow. And the reason for that is because obviously there's a tremendous amount of prescription volume going to CVS. There's purchases that are being made. And there's also care that needs to be delivered. Like, you know, my dear friend Cara McNulty was, you know, responsible for getting mental health delivered in, minute clinics. Well, there's clearly a need to do things like that, but I think you have to continue to, figure out where your place is and stick to that and stick to what you're good at. And some of these other companies really just grew too quickly. And also, you guys know the overhead with running a clinic. If you add staff, if you add new EMRs, it becomes bloated and you can't run a clinic effectively. And really, clinics run at, 3-4% margin at times. And there's not a lot of room to do things differently. So I think we're just seeing kind of the consolidation that's natural, and we'll come up with other ways of delivering care, that are innovative. It's unfortunate though, because those are needed. And if you look at where they're going out of business, it's really in the underserved areas. So
It's a big reset and a big a serious downturn in retail health, right? Like that would a lot of investment, a lot of thinking, a lot of time went into that work, including the work that you and your colleagues did. And for all kinds of reasons, it's kind of, collapsed. There was a really interesting Wall Street Journal story and podcast about the Walgreens situation, which is a whole nother story about decisions that they made with regards to Village MD and the structure of that and how that is falling apart and what that looks like for them. And fundamentally, as we know, Walgreens, sold to private equity, totally going to change. Massive. They're going to sell off or have already sold off their investment in Village MD, and question marks about what happens to that. So really hard business and really complex, and lots of work happened that is currently collapsing.
It's really sad. I don't know about you guys, but I use Minute Clinic all the time. But now with telehealth being extended, I think Minute Clinic solved a problem when we didn't use telehealth. We thought telehealth was crazy, and so now that telehealth is mainstream post COVID, I think we'll see that contraction and a shift more and more, maybe from Minute Clinics to being in person NPs to having more Higgy-like portals where you're talking to a physician or an NP on a monitor within a CVS store. Those are popping up already.
Very cool.
Yeah, different.
Okay, so you've been doing what I think is pretty cool stuff, right? Like I care about moms, I care about opioids, all these things, right? And then the justice involved individual population, right? That's very complex. So and these are problems not a lot of people have been able to solve. I know we have we got reproductive health startups and do all these wraparound services that primarily are focused on employers, right? And more on the commercial market. As you've gone through this very tricky environment, what has been the dumbest policy barrier that you have found? Other than, ACOs are not whatever. ACO's not.
It's not a policy problem. It's an implementation problem.
Oh my God.
That implementation matters, as Lisa already says.
Remember.
Yeah.
That is a tough.
What's the worst?
Oh,
you can give us a handful of them. You can give us a handful. You can be like, well, this sucked.
Well, I think, one is, why did states not more quickly sign on to the 1115 waiver for covering people who are in the process of reentering via Medicaid? To me, that is really stupid, because what you're seeing is people are covered by the justice system, and then they have to leave. They have to find an insurance company that they want to either get Medicaid through or exchange, or if they're employed. And that's a whole process. And then you have a gap in care that already exists. And if you have opioid use disorder or some other type of substance use disorder, you cannot afford to have a gap in your medication. And essentially, by not insuring those folks pre-release, we're forcing a gap. And so, we wonder why people dying from prison is 10 times more likely in the first 2 weeks when they're released. Well, it's logical. If they don't have their medicine, it's like asking somebody who's a diabetic to not take insulin for 2 weeks, or somebody with heart disease to not take their pills. It is a chronic condition that somebody needs meds for. And there's no reason why we should not be ensuring that people transition effectively in a way as though it's a chronic condition. And so I think that's kind of the stupidest decision, or stupidest lack of decision that's been made. Because also we found that when you actually offer care that way, it reduces recidivism rates by 64%. So hello, saving money
The
again,
data are there,
opportunity.
right.
It's staring us in our face and we're not able to make decisions around it. So to me, that's really dumb.
Why do you think they didn't sign up? Stigma?
I think because of funding. You know, it costs more money. I think figuring out how to sign up and get people enrolled when they're in prison is hard. How to actually get in touch with them and coordinate care when they're in prison is also difficult. But we did it. I don't know why it can't be done more broadly. But I think, you know, we'll continue to see these pockets where there is innovation, and hopefully more and more people will start to tackle that, you know, even with 1115 waivers being pulled, you know, that investment is still needed. And frankly, it's a white space for investors. You know, we run a company and we have an obligation to our shareholders. We are not a nonprofit, and we can run a business around it. And if we can, why can't others? So,
Right.
you know, I'll ask that question in kind of a provocative way.
I mean, it's a great point, and also again, I do think that stigma surrounds everything related to substance use disorder and reentry and justice involved individuals without a doubt. But it's one of those things where, man, the numbers just are pretty stinking obvious. If you can just get over your stigma and get over your idea that everyone should somehow magically bootstrap themselves to the moon or whatever, it just doesn't that's not reality. And the stigma isn't helping anybody. It's not improving outcomes. It's not reducing costs. It's not doing any of those things. So let's stop it.
Yeah. I mean, Chris Thompson, Kat, have you met him, or Lisa with Sober
Sidekick.
Yes.
We love that guy.
Oh, Sober Sidekick. Yeah, we met him. We interviewed him on the show at the behavior. Wasn't
He is.
Tech? Yes.
So if you talk about, you know,
Cool.
why this is not being invested in, he is the most passionate human being. You know, I love that guy. Amazing guy. And I think, you know, when we start to shift our orientation in a way where that's more akin to Chris, then we'll start to have empathy and see a different side of care delivery. But until we have that empathy, it's going to be treated like we don't want those patients. Those are hard patients. We want the easier ones. And, you know, somebody's got to do
Let's
that.
make a call, because Kim Kardashian is apparently still relatively influential in the space, and also in terms of she does a lot of like Innocence Project and getting people released.
Mm-hmm.
So this is something else Kim could work on. Kim Kardashian, use your
come on our show,
right?
Come on our show.
But also like help us make this policy, you know, universal around getting people support when they are, you know, leaving prisons and jails. This is critically important, and it results in major improvements to recidivism and, you know, better health outcomes and, you know, lower instances of substance use disorder, people managing their conditions, right? This just makes sense and like could use more visibility.
And it saves money. I mean, ultimately, if we're all looking at ways to save money,
right,
that is a really obvious way. And, you know, I continue to call into question why, if that's the focus, why are we not doing it?
That's right.
Yeah. Yeah. I wonder if there's some, you know, I know some states are more creative than others.
We have great ideas.
Yeah, we
absolutely.
do. We have great ideas. But yeah, I know some of the states, you know, are very, very much involved in making sure that justice involved individuals are a priority for Medicaid and opioid use disorder. What do you think is going to happen? Like, are some states going to fill the gaps with their opioid settlement funds? Right. Like, what do you?
I feel like Melissa just tagged Kim Kardashian, by the way.
Oh my God, that's awesome, Melissa. We love you. Yeah, like really, are we just going to see a lot of these advances go away, or?
I think we are. I mean, think if you know, we move to block grants. It's if we, kind of change provider taxes and the way that impacts the matching payments, I think we're going to start to see, we're not going to see a reallocation of the opioid dollars because those have been spent. People have fought over them. They're spent. It's gone. It's more who's going to step up to the plate and think about how do you solve this problem creatively versus trying to fight for funds. And I think, unfortunately, we're going to see a lot more deaths probably, especially people who are coming out of prison because of the lack of care, lack of funding.
Right. Not a good outcome. Pretty terrible.
So for those venture firms out there, I think, investment thesis around this makes money. It's fantastic. And I think more venture firms should start looking at this space because it's white space where there's lots of opportunity for innovation. It's not just, a public health issue.
Love it. Love it. And public health is still going to be important, y'all. Maybe we'll call it something different. I don't know, but we'll do something. And I think the numbers won't lie. I mean, it TBD if we get to see numbers that aren't lies though. So, I don't know, we'll see what happens there, but I appreciate your focus on it, Sarah. I do think there are a lot of companies out there that can make money on this and it is something viable for investors. I was involved in one as well, and you can find the right people to do cool things. But we have exactly 1 minute left. What would you like to tell all of America?
Oh God. Stop watching the news. And
stop watching the news.
Just watch the fake news, y'all.
Watch the fake news.
We're here. We're here.
I can tell you, it just increases blood pressure. I think that will save money. If we all stop watching the news, our blood pressure is going to go down and we're going to make America healthy again. So
there you go.
Sara Ratner for the Baja Council. Oh my gosh, amazing. All right. Well, Sarah, you're the best. We hope you have a great weekend. We hope the Canadians do not cut off your power. We like them. And we'll see what happens tomorrow, y'all. Maybe there'll be a rift tomorrow. Maybe it'll be later today. We don't know. So
we will find out.
Excited to find out. And we will possibly report on that later on our fake news show. So thanks for joining us, Sarah.
Thanks everybody.
Thanks everybody who commented, and we'll see you later.
That's right. See you later.
I know.